For the agent that must be in the know, Medicare Industry Insider discusses critical insight, noteworthy trends, and upcoming issues in the Medicare market.
Deciphering and debating the legislation, regulation, and what's happening in the market. I'm Chalon Jackson.
And I'm Rachel Brameyer, and we're going to talk shop, dive deep into these complex topics, and make them understandable and actionable.
If you've ever wondered where the world of Medicare is going and how to prepare for the future, Medicare Industry Insider is the resource you've been looking for.
Welcome to another episode of Medicare Industry Insider. Since the inception of Medicare, about 58 years ago, Medicare has been the test kitchen for the world of healthcare. So today we're going to continue to discuss not only Medicare, but how it is a test kitchen for the CMS Innovation Center. The Innovation Center is a place where they can test ideas and spread information about novel ways to deliver care. And it is a way that we can look at if Medicare is the right direction to go, if there's new ways to do things, and basically figure out the best way to deliver care effectively and also efficiently, cost-wise as well. So that is today's discussion, is CMS Innovation Center.
Yeah, and I think it's a really important fact to talk about what you mentioned with Medicare kind of being a baseline, and not just a baseline for other health insurance. We know that a lot of commercial plans are indexed to Medicare costs or Medicare pricing. A lot of other things base their payment models and structure on what Medicare pays for certain services. But it also affects a lot of other things because Medicare is kind of the big stick that Congress has to swing around when they want to change the industry of healthcare or the way healthcare is delivered. Because in a lot of cases, they may not be able to directly force or enforce a law on commercial or private payer plans, things like that. Medicare is something they very much can directly affect. The threat of not being able to accept Medicare and Medicaid payments is a big incentive to drive change in the industry, and one that we see on an increasing basis as Congress looks at things like PBMs and pharma companies and how things like the 340B program are run and a lot of other things, even up to and including Medicare drug pricing negotiations.
Right. We're seeing a lot of that with the Inflation Reduction Act too.
Absolutely. So. But the administration of Medicare has gone through a lot of changes over the years. And I think this CMS Innovation Center has become the hub for where we get to test out a lot of the things that people say, well, maybe we can improve care. CMS comes up with these goals, the strategic vision, and they say, how do we get there? The CMS Innovation Center is where those models go to be brought to life and be experimented with.
Yeah, and on top of that, the Innovation Center, just because you're doing something for almost 60 years doesn't always mean that it's the right way to do things. And so this is something that the government has. It's a nice little experimental place, imagine goggles and all the little testing pots and things. What is the word for that?
A laboratory?
Yeah, no, not the laboratory. I was thinking of the beaker thing. Anyways, beakers, that's what I'm thinking.
There we go.
Yeah, whenever I think of the CMS Innovation Center, that's what I visualize, even though it's not actually.
More like accountants sitting in an office somewhere.
Yeah, that's probably actually what it is. But we were taking a look at their website. There is currently 82 different models, which was shocking to me because I didn't expect that many models to be out and about and that had been tested over time. Again, the 82, they include ones that they've withdrawn or that have are no longer active, things like that. But there are quite a few active right now or that are currently being tested. So we wanted to dive into that just a little bit to go over some of the different testing models that are currently active or have been active recently. But they go into different topics like the accountable care models. And you've heard of the ACO REACH a lot in the news.
Sure.
We'll touch on that just a little bit. Disease-specific models, statutory models, health plan models. There's a lot of state and community-based models. And then, of course, we found, I think, at least one for prescription drug models as well.
Yeah. And I think it's really interesting to talk about how these innovative programs kind of develop. So in addition to being part of fulfilling CMS's strategic vision, a lot of this comes from other policy directives or initiatives or things that, maybe we know we can't pass as a law or can't get through rulemaking, it doesn't mean it's not something that we can't test out.
Right.
So even though we, for example, several years ago, and we'll go into this one here in a minute, but, one of the innovation model programs was the Part D senior savings model that capped insulin prices on a voluntary basis in partnership with both insurers and manufacturers through the Part D program. And that was a really good example of something that Congress had put a lot of effort behind, that the president had put a lot of effort behind, and they couldn't quite garner enough support to do that across the board in the healthcare industry. So they created the senior savings model, which was kind of that genesis of the permanent cap on insulin prices under the Inflation Reduction Act. And then even
just
beyond
taking a little
that,
piece of it and using it for something that actually exists now.
Exactly. And then even beyond that, further pressuring manufacturers and payers to create, now several major manufacturers of insulins have made that cap extended to commercial payers and then insured as well. So we do see that some of these models can pretty drastically affect outside of just Medicare, Part D senior savings model being just one of the many, many examples. But there's a lot of really interesting stuff going on right now that some of it we have data on, some of it's just starting, but lots of cool stuff going on.
Yeah, so I mentioned the ACO REACH initially, but I'll dive into accountable care is one of the models that they have for the Innovation Center as one of the topics. So we actually chose, this is the only one we were kind of picking two examples on because we've heard a lot about ACO REACH, but we wanted to at least bring another option into so you can kind of visualize when we say Innovation Center, some of the things that are actually happening and make it a little bit more tangible and real. But the ACO REACH program had 132 participants. So that's another thing to think about is some of them have one or two participants and some of them are thousands. So it's interesting to see how many people are willing to sign up. And that's another thing. You can sign up for these if they're available in your area if you wanted to be a test subject and check out that lab, get those speakers ready. But anyways, the ACO REACH, the main goal behind it was basically taking a look at care and making it's accountable care. So making doctors, providers accountable for the care they're providing and communicating across all boards. So basically promoting leadership and governance with providers, and then also allowing beneficiaries, whether they're on Medicaid or low income, to still have say in their care and have more understanding about why they're getting the care they're getting. But that was the main goal, is basically to make sure that the patients have improved health because of that. And so that's what they're watching, is just making sure that the providers, anyone who has any medical issues are getting better and it's improving their care opposed to a non-ACO option.
Well, and I think one of the big things to mention with this and all of these innovation models is, why would a provider group in these cases of ACOs, why would they take on the costs of administrating such a program? Because it does require additional administrative burden. They've got a lot of reporting they have to do back to the Innovation Center to make sure that they can track how these programs are going. But it's about more than just, specifically how care is delivered. It's also about creating innovative payment models within Medicare. For example, with these ACOs, it's a value-based model where you're getting paid based on savings to the Medicare program compared to a baseline. So it's really a method not only of rewarding provider groups that are offering better than average care, it's also a way to look at, can we provide better care while saving money?
Right.
And I think that's the key to a lot of the models we'll talk about.
Yeah. 100%. Yeah. And I appreciate you bringing up the savings part too, because that's something that the government's, like we said, it's a test kitchen to figure out if this is a better option to save money. Because at the end, that's the end goal with all the health insurance, is better care and more money saved. So with the ACO REACH, the only other thing I want to mention on that is the program also allows some extra unique, innovative things like telehealth visits, home health care after leaving the hospital, which isn't usually heard of as much unless you have maybe a Medicare Advantage plan that provided it, and then help with copays. So there's a lot of little unique things that they're doing to try to keep that person healthy. And then hopefully if they're healthy, then that's going to decrease some of the cost also.
Absolutely. Providing those additional flexibilities to providers, because a lot of times, this may be a large provider group with a single ownership that has, outpatient clinics and specialists and a hospital all in one network. But the idea behind these ACO programs in general is to create health communities of, maybe disconnected, but providers that can work together to better advocate for those clients through better record sharing, better communication between specialties or between specialists. And a lot of these models really drive towards primary care steering the ship of someone's care, both in and out of the healthcare setting. So I think there's a lot of aspects of this that really drive to look at whole person care, not just medical care.
Yeah. And I love that thought process. I think there's a lot of different, as we go through, we'll see a lot of that theme kind of going through it. The other one we wanted to mention on accountable care is make care primary. So this is one that a lot of people probably haven't heard about yet. It's going to start this year, late summer 2023, opening up to participants to sign up and be a part of this particular innovative care model. But it is brand new, and it's basically seeking to allow partners and specialists in the community to connect and address healthcare-related social needs. So it's kind of similar to the ACO REACH, just a little, again, it goes back to keeping primary care physicians as a primary driver of their care, and also holding them accountable for the care.
Holding them accountable for it. And I think also looking at, again, this idea of whole person care outside of just the medical realm. So looking at these social determinants of health, looking at other community services that, really kind of forcing providers, but also incentivizing them to become a real hub for their communities, where it's somewhere where you can go to get help, not just with your acute health needs, but also maybe some chronic underlying social issues that are impacting your health. And again, at the end of the day, costing Medicare more money.
Yes, 100%. So the next one that we wanted to address was health plan models. So the first one was basically accountable care, so providers. This one is more health plan related. So one that when we were going through, there was a lot of them.
Yes.
But one of them that we thought would be interesting to bring up in this one is the innovating, it's basically the Medicare Advantage value-based insurance design, or the VBID design model. So we'll dive a little bit deeper into that, but essentially it is a test kitchen to look at complementary health plans innovation and to try and reduce the Medicare expenditures and enhance quality of care for the beneficiaries. So they're testing different components of healthcare to try to figure out outcomes and lower the cost for Medicare Advantage enrollees.
Absolutely. And I think what we see with this are a lot of the very socially driven benefits that you'll see on certain Medicare Advantage plans. So you can see things like utility assistance, transportation, some of these other social determinant of health impacting benefits that are maybe not available to all beneficiaries. And again, a lot of these programs build upon each other. So we're going to talk about some other models later that are maybe a little bit older, but they really have built upon some of these things to create new models, because a lot of these only run for a fixed amount of time. And then we have to come up with the next thing to say, okay, what did we learn? And then how can we maybe tweak the system? So looking at VBID, value-based insurance design, the big thing is just about removing obstacles. We wanted to make sure that patients have really tailored supplemental benefits, things like assistance with prescriptions, grocery assistance, making sure they can actually get to their appointments. And that can take a lot of different approaches. That can be not just transportation services, it can also mean in-home support, managing, maybe through remote patient monitoring, maybe providing, support and counseling for chronic conditions. There's a lot of things that can go into how we design benefits that can look at a person-centered approach to care and looking at overall outcomes rather than, and this is the trend you'll see across the vast majority of these models, is a trend away from fee-for-service payment models. Everything that we're talking about today, for the most part, is really focused on how do we get away from paying based on a list of prices for particular services, and how do we start paying for patient outcomes?
Looking at the person as a whole and making sure that, 'cause that's the ultimate goal. If you're taking care of someone, they should stay healthy or at least take care of chronic conditions before they get worse. And when we're looking at just services and the grind, it's not always looking at that individual person. So the neat thing with the value-based insurance design model is that a lot of plans are actually participating in it right now. We actually, for 2023, they have 52 participating Medicare Advantage organizations, which actually totals 9.3 million enrollees in this project. So the last one we mentioned was just a couple hundred, or not even a little over 100. This one has 9.3 million people participating. And so a lot of the things that you mentioned, we've all probably heard about, which is, like the getting people transported to their care, getting them some of those, personal health emergency response systems, things like that can help that person have better care.
Yep. And a lot of agents may not even recognize that they're involved in value-based insurance design. But if you've ever seen certain MA benefits that are maybe only available to certain beneficiaries, a lot of these are commonly available on D-SNP plans, or certain benefits that may have additional qualifications, may have to send in documentation of chronic illness or various other things, all part of the VBID or a couple other related programs, really, again, geared towards getting innovative types of assistance to people that need it most.
Right. Yeah. So, it's kind of neat because as we're saying this, you're probably going, oh, I've heard of that benefit. Oh, I've heard of that one. And that's why, because there are so many plans actually participating in this particular health plan model. So the next one we want to go into is disease-specific or episode-based models. And there was a lot of different options, but cancer has been huge in the industry, huge topic. Even with the new initiative that I believe the Biden administration started. So, it's definitely been huge in the industry to talk about. So we picked oncology. It's called Enhancing Oncology Model. So basically the aim for this is to improve care for anyone receiving oncology care who have different types of cancer, but basically reducing, like Jalen said on the other one, the fee-for-service model currently in place.
Yep. Big focus again on this idea of accountable care is not just being accountable for the patient's outcomes, but being accountable for the financial outcomes for the program. So looking at, again, trending away from fee-for-service and trending towards both financial and performance accountability. And a lot of these take the form of what we call a shared savings model. So where if there are savings to the Medicare program, the provider or provider group or accountable care organization or whoever it may be, participating providers will receive a portion of that savings as basically a bonus for providing that additional level of care and improved outcomes. If there are costs beyond what the fee-for-service baseline is, those providers can be held accountable for paying back some of that to Medicare. So it makes sure that providers have some skin in the game with not only these new models, making sure that they're run efficiently and effectively, but also making sure that we're hitting that end goal of patient understanding and choice for the direction of their care. In this particular model, really looking at coordinating across providers, not just an oncologist, but helping them navigate and manage care across all the providers involved in that spectrum of client experience.
Yeah, and it goes beyond even providers, which is really neat because they even go into like housing, transportation, socio-psychological health needs. So a lot of people who have cancer are dealing with a lot of mental thoughts of, what is going to happen to my family? Am I going to be able to make it? That's not always treated. A lot of times it's looked at as you have cancer, let's treat the cancer, let's not treat all the other things going on. So the other thing is it also touches and helps with the underserved population or people who are on Medicaid who may not have gotten the care that someone who has a lot of money and has a lot of means to take care of, maybe going to a psychiatrist or, treating the other issues when you are going through cancer. So it's specifically looking at better serving anyone going through cancer, in all aspects. Again, I think you're starting to see a theme as we go through this. All aspects of that person is being taken care of.
Yep, absolutely. And I think one of the big keys here as well is there's additional support available to certain provider groups who treat large portions of underserved or lower income patients. So beyond just the basic program, there's also additional things that can be provided to assist providers working with folks on Medicaid or that are dually eligible, or folks in perhaps rural areas or other, places of greater need in a traditional sense. So a lot more support available to those providers to help with access, treatment, and outcomes for those beneficiaries. So again, a really interesting model that's looking at how do we take traditional care models and take all of the best parts and enhance those while removing some of the barriers to care that people have faced.
Yeah, I love it. The next one we wanted to go on was a statutory model. So this one, there was again several options, and we ended up we wanted to highlight one that was independence at home. Again, this one, home healthcare and caregivers and all of that has been a huge topic in the news. So again, I think this one applies a little bit more to what you're currently seeing. It's interesting that this one only had one test participant.
Yeah, this was a really fascinating model. Given that it is focused on how can we provide primary care services at home in a beneficiary's dwelling to specifically folks with multiple chronic conditions, with the overall goal of kind of increasing independence, reducing reliance on institutionalization, and then also reducing things like emergency department visits and other acute care needs by providing that care in place. And I think that's a big trend we're seeing, not just in this innovation model, but also across the industry, a lot more focus on how do we provide care to people where they are instead of bringing them into a new environment.
Right.
And it's as simple as things like, a lot of people, and we know this, people will test higher for their blood pressure at the doctor's office than they will at home, just because they're at a doctor's office and it makes them nervous and they're worried something's going to be wrong and they're thinking about all this and it gets their heart going. It'll up their blood pressure, in some cases, a significant amount. And it doesn't happen to everyone.
And on top of that, you're like in a new environment. You're not in your own bed. Your sleep is getting interrupted by people checking your blood pressure, feeding you, turning lights on to check different things. There's alarms going off and people are not resting and you need rest to recover. And also like whenever I was talking to someone at my grandma's assisted living location, and she said that there's a couple things people need to pass away. Sometimes people need to be at home. Sometimes people need permission, and sometimes people want to be alone. So it just depends on the type of person. But she said those have always been the themes that she's seen. And if someone is, not at home, maybe that's causing them to either hang on because they're not in a place that they feel comfortable, or they're not getting better. So you're probably seeing both ends of the spectrum. So you've got that aspect. And then you also have, we've discussed this in previous episodes, but the shortages of skilled nursing facilities and places where people, if we're going to uproot them from home and take them someplace else, do we have space? Yeah. So I think there's a couple different reasons why this model is being tested out, but I like it. I want to recover at home if I get sick. So.
Sure. And not just recovery, even just, managing chronic conditions in a way that they don't lead to acute needs that can only be handled in an institutional setting. And even though this is currently only has one partner, the big thing is, look at the Innovation Center occasionally, and a lot of these programs have kind of an ongoing or annual enrollment opportunity for providers and new partners to join the model. So it's a lot of really interesting things going on. This particular case is happening in New York with again, that single partner for the test, but, pretty early on, but by and large, coming up with some good results, it seems like, and we'll really look forward to the data that they publish on this particular study as it reflects a lot of things that are happening in the industry as a whole.
Yeah. So the next one we want to go over is state and community-based model. So this one didn't have as many options to pick from, but the one we ended up choosing was accountable health communities model. So this particular model is aiming to bridge the gap between the medical care and the community resources. So you're going to see a lot of things like food and social needs, basically insecurities that cause people to get sick.
Absolutely.
Or not get well.
Absolutely. And I think a lot of this comes from, doctors will tell you one of the biggest problems in healthcare is getting people to appointments and getting people to take their medications. And a lot of that stems from other social determinants of health that are not being met. If you have to choose between your gabapentin and groceries, it's a pretty easy choice for most people. Not to say it's easy to make that choice, but it's easy to prioritize one over the other when it comes to the immediate need versus the long-term need. So I think that's what this particular model tried to address. And it's really interesting because unlike some of the other models we've discussed, this is one that actually has published some data. It's been going on since 2015. And the early data showed some really interesting things. So not only did this model address those health needs, and it did, in fact, statistically significantly reduce emergency department visits as well as return visits to the ER after receiving care. But we also found there are some issues beyond healthcare and beyond connection to services that face people who have issues with these social determinants of health. We actually saw no significant change in some of these significant social factors such as food insecurity and housing insecurity and various others, because what we found was connection was not enough by itself. While these providers in this system were, empowered and encouraged to connect people with resources, we found that navigating people to the local food bank, the local, housing authority, whoever it may be, isn't necessarily enough. They actually identified kind of 4 primary factors that prevented folks from getting the help they needed. And over 77% of people accepted navigation. Less than half of them actually got the help they needed. One of the biggest things was lack of transportation, not being eligible for the programs they were being connected with, long wait times, or lack of funding. So what we found was not so much that being connected with resources is the issue. The issue is there are not adequate resources to serve the population that needs them. And I think that was one thing that really came out of this Accountable Health Communities model was we found that there is a real need for some of these social services that are not currently being met in many, many communities.
100%. And I'm just thinking of an example too of talking to, I don't even remember which carrier rep this was, but they were talking about how they send out a skilled nurse to their people's homes as part of the Medicare Advantage benefit. And they came out and this person had incredibly high blood pressure and they couldn't figure out, they were like, you're healthy, there's nothing wrong. Like, do you take any medicine? The next thing they do is they look over at their kitchen and there's tons and tons of soup cans just lined up on their kitchen. And they're like, is that what you eat? And they're like, yeah, I can't really afford vegetables or they go old too fast and I don't have the means to get there, and soup's just easy. I can stock it up and it doesn't go old. And they picked it up and looked at it. The sodium levels were incredible, which was causing this person to have high blood pressure, which was causing other health issues. So like little things like that where you can connect the whole holistic version of this person sometimes can help prevent some of the major health concerns that you run into in the future. So that story was, being told as like an example of them sending out a nurse practitioner. But I think what you just said, Shaylin, of like looking at this person of like, do they actually have the means to get to where they need to go to get the benefits that they have? Do they have the means to understand the difference of like food and the benefits of different types of, like, a lot of that just isn't being looked at as a holistic care. So I think this model definitely takes that into effect of trying to look at those insecurities with the community resources.
Yeah. Well, and even backtracking to a couple of the other models, VBID, for example, while we do see a lot of Medicare Advantage plans with things like transportation benefits now, because of the limitations within the program, there are still gaps in the system. Those transportation benefits are fantastic to get someone to a doctor's appointment or physical therapy or something like that. That's the only places they're allowed to go.
They're not going to the grocery store. They're not going.
I've heard from a lot of agents of people being willing to pay more for their prescriptions, switching their pharmacy to Walmart, because then they can get a ride to pick up their prescriptions. But now they're at the grocery store too. Yeah. And they're willing to pay more for their prescriptions because that's a bigger need for them. Yeah. So there's a lot of kind of gaps in there. But one thing that I found particularly interesting in the Accountable Health Communities model was some data they had on skilled nursing. And this was a program that actually allowed doctors to waive the 3 midnight rule for skilled nursing stays. And in fact, we're able to send people and refer them to skilled nursing without a hospital stay at all.
So doing what's right for that person, not because it's, a guideline in their insurance.
Exactly. And again, not only did it, increase that patient experience and improve patient outcomes. Again, they did see one of the statistically significant outcomes were lower emergency department visits, which of course are traumatic for patients, expensive for the program, and generally something we like to avoid.
Yeah. Absolutely. So before we wrap this up, I did want to mention there's a phenomenal map when we were looking at it. So if you go to innovation.cms.gov, there is a map that will show you where all the different innovation options, all the different models, the state metrics, who's participating. So it's really neat. You can kind of see what is happening in the United States, where it's happening. And we had probably too much fun playing around with it while we were prepping for this one. But it is kind of fun to see just the different types of models that are out there, the different ways of thought processes that are happening. And I loved how you had even mentioned with the prescription drug model in the very beginning, how a piece of it was actually utilized for the Inflation Reduction Act. So while it wasn't actually, used after the fact, it was still a portion of it, or a thought process was used. So I think that's the end goal, is just always be inventing, always looking for something different and better. And making sure that we're just keeping the idea of there might be some, better way to take care of a person. There might be a better way to pay for things. There might be a way to prevent people from getting chronic conditions, or even get them to the right place, like how you mentioned Walmart, because they have a grocery store. So,
well, I think one of my big call outs to agents before we wrap it up is, be aware of the programs that are happening in your area, because it's really common for us to get a call from an agent and says, hey, my client got this weird letter from their provider, something about a network, but I don't understand because they're on a supplement. What do you mean a network? And I think that's one thing that people really need to understand is most of these programs that are specifically the accountable care models and some of the other statutory models and things like that are specifically tailored for fee-for-service Medicare or original Medicare. So it's not going to affect your Medicare Advantage clients. Some of the other ones like BBID, Part D savings model, some of those will affect all clients across the board, but many of these are geared towards original Medicare. So if your client's getting a weird letter, if they're getting something that doesn't make sense, that's one of the first places I would go, is look at the Innovation Center, look at the doctors they're seeing. Maybe they're in a provider group that's part of one of these innovation models, and maybe we need to do a little research so that we can be part of that care community to make sure they're getting access to the things they need.
Yeah, and if there is a care model available in your backyard, that's one thing that, if the resources are there, they're going to get, like we just mentioned, a lot of ways to connect that person to get better care, lower costs, maybe extra benefits, all at the same time, hopefully giving them a better access to what kind of care they're getting and understanding the type of care they're getting. So definitely check it out and see if there's anything in your backyard, because that's a very good point, Jalen. So as we wrap this up, knowing that it's not going to affect Medicare, not any of your Medicare clients, but Medicare is, like we called, the big stick, or the test kitchen. We've used a couple of those words throughout it. It is where Congress can, swing at providers, insurance, and pharma companies to force any changes in healthcare. This is a way to test things out without making those big shifts, but allow us to kind of think outside the box in terms of better access to care, cheaper, saving money, and basically making sure that person is holistically looked at. So with that, we'll wrap up this particular episode of Medicare Industry Insider. Thank you so much for watching, and we hope you enjoyed it.